Right, okay, good evening, everybody. It's a couple of minutes past 7, so hopefully everybody's managed to join now. So we'll get started. Welcome to another Medical Projects webinar Wednesday. My name is Mark Williams and the founder of Medical Projects, and we've been helping students with their kind of medical school application and work experience for the last kind of 5 or 6 years. And we've recently started doing a series of webinars just to try and help students along with their applications and kind of provide some insights and some opportunities that might be a little bit difficult to get at the moment, given the whole kind of lockdown situation and how things have changed with, the ability to get work experience. So we wanted to kind of spend a bit of time actually talking to somebody who we always get questions about when we kind of run projects. When we speak to students about kind of, what do you want to do within medicine? Probably the most popular answer that we get is, I want to be a surgeon. And so we thought we'd kind of get a surgeon in, and you could ask them the questions that you might have asked if you were, say, on your work experience placements. And kind of ask the questions that you want to get answers to. And hopefully we can shed a bit of kind of reality on the situation and the job for you as well. So I'll just go through a little bit of kind of housekeeping stuff for those of you who haven't been on one of our webinars before. So obviously we're using Zoom. I'm sure a lot of you have used Zoom in the past, in the past few months. But the basics are that we have a chat function down at the bottom. So if you need to send me a message, you can send kind of me a direct message. If there's any issues with any of the sound or anything like that, feel free just to drop us a message. We also have the Q&A function as well, which we'll be using later on, because I'll ask a few of the questions that students have sent in to us in the past or recently, and then I'm going to open it up to everybody to kind of ask questions that they would like to ask James, our surgeon. So the Q&A function also has like an upvote system as well. So if anybody has asked a question that you were going to ask, you can just kind of hit the thumb button and it kind of votes them. It just means that we can see the most popular questions, and it means that we can get those answered for you. We have about kind of 45 minutes, and I want most of that to be kind of filled with your questions as well. So like I said, we have some students have sent in to us before, so we'll start with those and then we'll kind of open it up to you guys. We will use a couple of poll questions as well, just to kind of gauge kind of where we're at with the students that are kind of watching this webinar as well. And that just helps us work out where we can kind of pitch some of the answers and some of the responses as well. So let's jump straight into that. So the first question is just for us, just to see who is watching our webinar this evening. So it's just have you attended a Medical Projects webinar before, yes or no? Cool, so we'll just give that a couple more seconds, give everybody a chance to vote for this one. And I'll share those results with you so you know who's watching as well. So it's nearly a 50-50 split. Kind of 55% of this is the first webinar you've ever seen, which is fantastic. Welcome. And for those of you who've watched our webinars before, welcome back. And I've just got one more question as well, which is about kind of when you're looking to apply to medical school or whether you're still thinking about it as well. And again, that'll give us a good idea of kind of where to pitch some of the answers throughout this as well. Just a couple more seconds on that one as well, and then we'll share those results so everyone can see. It's all anonymous. You can only see the kind of the combined data that we can see as well. So Great. So some of you have already applied. You've obviously just submitted your personal statement a couple of weeks ago. And a lot of you are applying next year, which is great. You're kind of already looking for opportunities and searching out insight, which is amazing. Those of you applying in 22, you're way ahead of the game, so well done. And those that are kind of later, still deciding, that's great. Well, hopefully you can kind of pick up some helpful things from this as well. Cool. So at this point, I'd like to introduce Mr. James Olivier, and we'll probably go through why he's a Mr. rather than a doctor in some of the early questions. So James is an ST5 registrar in general surgery, and he's here to kind of answer some of your questions and just give you a bit of insight into what life as a surgeon is like, and kind of what that process of becoming a surgeon is as well. So I don't know if you're there, James, or you can just kind of turn on the camera. There we go. Hi, how are you doing?
Hi, can you see me okay?
Yes, I got you, yeah.
Fantastic. Thanks so much for having me, Mark. This is a brilliant opportunity to be able to have a chat and inform hopefully some prospective medical students about life as a surgeon.
Yeah, thanks for joining us. I know you've had a busy day, so to take some time out of your evening, we really appreciate it. I'm sure the students do as well. I mentioned in there as well that you're an ST5 registrar in general surgery. Kind of, do you want to just tell us like what that means for somebody who's not kind of working in a hospital? It can be a little bit confusing sometimes.
Absolutely. So what I'll do is I'll first tell you what general surgery is. I'll then tell you what the pathway to becoming my stage of general surgery training, and then I'll go a bit probably about myself into sort of terms of my training and what I did. So first of all, general surgery is quite a nebulous term, pretty non-specific, but it's historic in that general surgery used to be the sort of vast mainstay or majority of surgery. These days, it tends to mean abdominal surgery on the whole. It does include some other aspects, but the mainstay is abdominal surgery, so predominantly sort of bowel surgery, gallbladders, livers, and everything else inside the abdomen. It does include things like abscesses, things like a specific condition called necrotizing fasciitis, or skin-eating bacteria, as you might have heard it. And often things to do with the head and neck. So for example, lumps in the neck, thyroids, parathyroids. So it's a slightly unusual term, general surgery, but it's slowly becoming more specific. So first of all, that's general surgery. We can always go into that in more detail later. The next thing to discuss really is ST5. And that just means a number. So it's a specialist trainee at level 5. And you finish training at ST8, although it is very sort of specialty specific. So there are certain specialties which finish at 5, 6, 7, or 8, but 8 is definitely the highest. So what I'll do is at some point later, I'll go through the entire process of how you become a consultant in a profession such as surgery. And is there anything so far you wanted to pick up, Mark? Is that okay?
No, yeah, that's great. Obviously, we can go into kind of the stage from medical school to the stage you're at, and then on to that kind of consultant stage. But maybe if we kind of go back to, I know it might be a few years ago, but your kind of medical school days. I don't know if you just want to let us know kind of where you went, and then what happened kind of for the first couple of years after leaving university, because you don't go straight into being a surgeon, do you?
That's right. Yeah, definitely. Happy to. And again, later we can pick up on specific points if anyone's got any questions. But for now, I'll go into a bit about university life. So I went to school in South Wales in a small village called Caerleon. It was a comprehensive school. I didn't go to a private school, and no one in my family has been a medic or in the medical profession at all. I think my father was the first person to go to university in our family. Then I applied to several universities. I got places at Cardiff, I got a place at Nottingham and Bristol, and I got a rejection from Southampton. I then took a place at Nottingham because I thought Cardiff was a little close to home, and Bristol was very nice, but just Nottingham really attracted me. So I went to Nottingham, and that was so I was applying in 2008, and I went to Nottingham in 2009. I then spent 5 years at Nottingham. I'm sure some people on the webinar will be familiar with Nottingham's program, but they include a intercalated degree, which is a B.Med.Sci, Bachelor of Medical Sciences. So when you come out of Nottingham, you come out with 2 degrees, which is the advantage, without having to do an intercalated extra year. So you come out with a BMBS, which is a Bachelor of Medicine and Bachelor of Surgery, and you come out with a B.Med.Sci, which is essentially a BSc. And that, alongside it being a sort of beautiful campus and a nice friendly place, was what drew me to go to Nottingham.
Okay, yeah, that's great. It's great to kind of hear about that kind of start part of the journey. So then, obviously, you kind of graduated. You said that you essentially get 2 degrees as well from that program in Nottingham, and then you have to go into being a junior doctor. You don't go straight into a surgical pathway, do you?
That's absolutely correct. Yeah. So 5 years, or 6 years, depending on where you go to university, and you may be a graduate, you may be an undergraduate. But say you went, at 18 to university, then you finish at 23, 24, depending on where you go, what age you are, and then you become a junior doctor. And to clarify, junior doctor is anything from an F1, which is the first year, up to, but not including a consultant. So you may be a very senior surgeon, yet be a junior doctor. So when you finish university, say you're 23, 24, you then go and choose your where you'd like to be a junior doctor. And I chose Bristol because it's quite central in terms of the country, seeing various friends along the country, but close to home as well, and just a generally nice location. So I was an F1, which is a foundation year 1 doctor, and that was in 2014. And then you spend 2 years in the foundation program, so foundation year 1 and foundation year 2. That's standard. Everyone has to do that to become a doctor. And then you get your qualification for being foundation approved as such. So those are your first 2 years, and I did a combination of a few different jobs. You tend to rotate every 4 months or every 3 months. So I did my first 2 years in Bath Hospital in the Southwest. So I did 4 years of cardiology to start, and then I did 4 years of breast and endocrine surgery, followed by 4 months of each, and then 4 months of intensive care, which is brilliant. Then this was followed by F2 in the same place, and often it's in the same place, but sometimes it can be 2 different hospitals, and that's something to think about when you're applying. And for me, being in 2 years for one long program is much better. You get to know the people and the place and the systems and everything else. So for F2, you're then classified as an SHO. This is a senior house officer, a very sort of old term which we still use, which means F2 to a few years going forwards. We try not to use it, but you will hear it, SHO. So that's F2, and I did 4 years of trauma and orthopedics, 4 years of geriatrics, which is care of the elderly, and then 4 years of general practice. So that was the next step. Is that all right, Mark, or should I carry on?
Yeah, I mean, if you want to carry on going down that kind of timeline, it's a nice kind of progression to take all the way through up to kind of consultant, if you like.
Yeah, sure. So the next step is you want to start thinking about what you want to do in terms of specializing. So this is where I chose surgery, and you can go down different routes, which I can go to in specifically later, but I chose general surgery. So in order to do that, you need to do core surgical training. This is CT1 and CT2, so core training 1 and core training 2. And this gives you a broad base on which to further kind of specify which type of surgery you want to do. So within core training, you generally cover multiple different surgical specialties. So you no longer do any medicine. You don't do any primary care, i.e. general practice or psychiatry. This is all surgery. So core training 1, I did urology, I did vascular, and I did colorectal. In core surgical training 2, I did upper GI, so upper gastrointestinal, and then another sort of set of general surgery and breast surgery. And then at the end of that, you're signed off as a core trainee, and you can apply to be a registrar. So we've got F1, F2. So say you were 23, you're now 25, finished foundation training. And then you do another 2 years, say you're 27, and then you can start thinking about being a registrar. And you can apply for a specialty-specific registrar training post. So I chose general surgery, which is the sort of broadest surgery you can apply for. You could apply for cardiothoracics, neurosurgery, pediatric surgery, whatever you want. But general surgery is what I went for. And at this point, you're now in ST3. Just to confuse things, it's very confusing nomenclature. So you're ST3, which is specialist training 3. So I did ST3, I did ST4, and I'm ST5 now. And as I said before, you will finish up to ST6 in general surgery, and then you are ready to be a consultant. At the end of that process, you get something called CCT, which is your completion of certificate for training. And that means you can be a consultant. Now that's the sort of really quick path, but most people won't go that quickly throughout. So a lot of people will take gaps at different points. And the most common places to take gaps are after foundation training, or after core surgical training, or core medical training, whatever you go for. But also within your training, you can actually take pauses, and you can go off and you can do research or education, management, whatever you're interested in. Or actually you can just go to Australia and sit on the beach for a year. It's entirely up to you. But you've got lots of options. So a lot of people get daunted about starting on that treadmill and not being able to get out. But actually, you've got lots of different options. And I think medicine is becoming more flexible to having a better work-life balance, which we can go into later. And you can have what's called a portfolio career as well. Is that okay, Mark?
Yeah, that's great. Yeah, I think that explains the timeline. If you were to go straight through, that's still a good, the best part of 10 years, 11 years, if you go straight through?
Yeah, the very minimum in general surgery would be 5 years of medical school and 10 years of postgraduate training. And of course, from F1 onwards, you're paid to do this and it's a job, but you're not fully independent and signed off until you're a consultant. It's a gradual process. So, there are many things now that I would do independently without needing a consultant around, but there's still many things that I would want a consultant around for to give me a hand or to learn from them. And it's a gradual process. So actually, when you're ST8 and you're senior, you'll be pretty much working independently, but you've got that support available.
So at what stage can you officially call yourself a surgeon then? Because there's a little bit of a title change as well between doctor and surgeon as well, isn't there?
Yeah, absolutely. That's a really good question. It's actually not that straightforward to answer. So some people would consider it when you become a mister, and some people would consider it when you become a consultant. So as we said before, you become a mister at a certain part of your training, and that's generally after core training, but it's specifically when you finish your MRCS exams. That's your membership of the Royal College of Surgeons. And it's a reasonably difficult exam where only 30% of people pass. And it's a kind of 4-hour slog followed by a what's called an OSCE, which is a clinical exam, a viva, where you talk through different cases. And it's quite tricky. But when you get your MRCS, you're then called a mister, which is, it may seem like a step backwards to go from doctor to mister, but actually, at least in the surgical medical world, it's considered quite, you're definitely respected more once you've got your mister, or Ms. or Mrs. But I think the key really is that you wouldn't really consider yourself a surgeon proper until you're a consultant and you can fully independently practice. I certainly wouldn't call myself a surgeon to the fullest extent of the word at this point anyway.
Okay, I'm just looking at through some of the questions that the students have sent in.
Yeah.
And obviously one of them is a kind of around what your day-to-day job or what your day looks like, and I guess that links straight back to the title of the actual webinar as well, A Day in the Life of a Surgeon. Mm-hmm. So what does a typical day or a typical week normally look like for you?
Again, this is not a straightforward question to answer because I know it's cliche, but every single day is different. For example, today I was ward rounding and I saw, I think it was 40 patients, some of which were well, some of which were really unwell, some of which needed theatre, they needed investigations, or they just needed someone to talk to. So that was my day today. But tomorrow I'm going to be in theatre all day, operating all day. The day after I'm in clinic all day. And you have multiple other activities. Actually, there isn't a single day that's normal. The mainstay of your sort of timetable, as it would be 9 to 5 or realistically 8 till 6. where you'd be working in sessions. So a morning is a session, an afternoon is a session. Each session is generally allocated to something. So you've got theatre, you've got clinic, you've got endoscopy, which is where you do camera tests, or you have some other activity. You might have a meeting, you might have an MDT meeting, which is where we have radiologists who look at the scans, pathologists who look at specimens, surgeons, and other professions who all sit in a room and make the best plans for each patient, mainly for cancer patients. That might be a session. Or you have what's called SBA, which is your admin time, where when you become a registrar, unfortunately don't really get it as a foundational core training, but when you become a registrar, you start to develop a lot of admin where you need time to do that. And by admin, I mean looking at test results and following up patients and things like that. So the mainstay of your time will be doing that. But however, you do work weekends, you do work evenings, and you do work nights. You can't get away from that. So it's definitely a lot more spaced out and a better balance than it used to be in the past. They used to work, you may have heard, about 100 hours in a week, but you're now capped at 48 hours a week in theory. So you definitely do get a better work-life balance than in the past.
You say in theory, does that get breached quite often?
Do you know what? I think medicine's getting better at stopping that happening, but there is still an aspect in surgery where if you have an unwell patient who needs to go to theatre, you're not going to leave halfway through the case. You have to finish that, solve the problem, and then you go home. So I think we're getting better at handing over to each other and finishing on time, and that's your shift, you're done. But at the same time, you wouldn't leave in the middle of an operation. So there is an element of give and take with that. And, you know, some days you leave early, some days there's less to do, and you can't really clock in and clock out as you would in, you know, an office job or something. You've got to be flexible with that.
And so just looking again at some of the student questions here as well, it kind of relates back to that's obviously quite challenging. You know, you might not know what's going on all the time, but, you know, what do you find as the most kind of challenging aspect of your job is at the moment?
I think there's a few different areas. Multitasking and working under pressure is definitely an area which always needs kind of constant working and improving on. You know, if you're doing an operation but someone's asking you something about another patient who's unwell, or you're on call and you're doing a trauma call in the accident emergency departments, but your bleep's going off constantly about other patients, you need to be able to prioritize and work under pressure. But that is something that comes with time. But it never is easy, I don't think. Another thing is the patients where you can't do anything for them. For example, their pathology, their problem is so advanced that the options you have wouldn't be appropriate. And that's always a difficult situation to be in, to have an honest conversation with someone and say, look, this is the problem. You've got, you know, for example, cancer, and it's not resectable. We can't take it out for you. It's always going to be difficult, kind of emotionally to take on for you and the family involved. So I'd probably go with those, to be honest with you.
That sounds pretty difficult. I'm sure most of us can't really relate to having to have those kind of conversations with families or patients. Are you trained on that, or is that something you just kind of thrown into and you have to kind of learn on the go?
Yeah, I mean, you're definitely trained, and I can say that it's getting better and better. Historically, that was sort of, well, you just do it. You have that conversation, you just deal with it. But we're sort of recognizing the importance of actually you can learn communication skills, you can learn how to do this properly, and that's a really big part of medical school curriculum now, which is, you know, only a good thing. But also the effect of the emotional toll it has on people in terms of, you know, if you've got really difficult trauma and the patient doesn't make it, for example, that's going to have an effect on the, you know, the doctor or surgeon. And we're recognizing that, and it does lead to burnout. And actually, you know, to be objective about it, we've invested so much in you as a trainee or as a surgeon. We don't want you being off work sick and unwell because you're stressed out. So I think that's becoming a bigger and bigger thing within the NHS and within medical schools, to recognize the stress of the job. So to answer, yes.
Okay, so that obviously that's some of the challenges as well, but what do you find is kind of the most kind of rewarding or most enjoyable part of the job then? That's the nicer side of the of the coin.
Yeah. So I mean, fortunately, I love surgery. I still love it, and I think I will continue to do so. I'm happy to stay late and do an operation. I'm happy to, sometimes going on my day off to do an interesting case. I think that it sounds cliche, but the fact that you can get a patient coming to the hospital who's drastically unwell with a specific problem, you can do the scan or whatever investigation, work out what it is, and then offer them a solution, and then implement that solution yourself and see the patient recover is amazing. So, I mean, if you have a patient, for example, who's got a perforated ulcer in their stomach, you can take them to theatre and you can fix that. You can fix that hole, fix the problem, and they're instantly better. Not to say they won't potentially have any problems or complications later, but you've gone from, an extremely sick person to a well person within a short amount of time, using the skills that you developed over time. So for me, that's one of the biggest pluses, but also just the variety of the job. Like I said before, one day you're in clinic seeing people with various problems, whatever it is, in different parts of the body. The next day you're in theatre fixing those problems, or you're doing endoscopy and diagnosing them with a camera test, or you're in meetings discussing patients, or you're doing other things like research or education. Just the variety within it is I think amazing.
That sounds good. It's definitely it's not a desk job, is it? You've got all these different things going on. It's variety is always going to be there, isn't it?
Absolutely. You'd be surprised how quickly a 13-hour day would fly by, honestly, when you're busy fixing problems and doing various things.
I think it shows that you enjoy it as well. When time goes quickly like that, you must enjoy it for it to go like that, which is good. So you mentioned that you kind of have to give up, or optionally sometimes you give up days on your weekends. You'd stay late sometimes as well. How does that kind of balance with general life as well? Because that's quite a commitment if you're giving up days of your weekend and things like that.
Yeah, I mean, that's a really good question. Having said that, I think you get a lot of autonomy as a sort of surgeon. You get a lot of say of how your day looks, how your week looks. And whilst you may stay late one day, you it's very reasonable to go home early sometimes when there's nothing to do. So it is flexible, but there's inevitably going to be those occasions where you miss a social event, you miss, whatever. But it is getting better. In the past, where people really struggled to, for example, get a wedding day off for their wedding, is a sort of thing of the past. You don't really see that anymore, and it's always a concern for everyone. But as I say, things are generally progressing better. You've got more options going forwards in terms of working part-time. It used to be that you had really specific criteria to be able to work part-time, but actually a lot of people now are deciding they want to work part-time as a surgeon, and that's fine. You don't need a reason. If that suits you, that suits you. A lot of people have what we call portfolio careers, so they may spend part of their time as a surgeon. They may spend half their time with a technology company or pharmaceutical company or their own educational company, and that's also fine. So I think that aspect shouldn't stop anyone going for surgery, but you've got to really like surgery. You've got to be able to give up some time towards surgery if you need to, but you've got to be flexible.
And just looking at the questions here as well, someone's asked, at what point you knew you wanted to go down the surgical path rather than, say the medicine or the primary care route.
Yeah, really good question. I don't think there was a specific point in time. It was a gradual realization, but I was extremely fortunate to be sort of taken under the wing of a massively inspirational surgeon in Nottingham. So he was a pediatric neurosurgeon. He was incredibly impressive, but also extremely down to earth and extremely approachable and friendly. And from day one of the university starting, he was my pastoral tutor. So you sort of have a nominal consultant who looks after you for the whole of the medical school years, and you meet with them regularly. And he was brilliant in sort of getting me involved in theatre. So it was initially sort of learning how to stand around in theatre, because it's terrifying and you don't know what to touch and what not to touch. And then gradually, this is how you scrub into an operation, and then this is how you assist in an operation. So actually, by the time I'd finished university, I realised I'd been to sort of loads of operations, and I really wanted to be a neurosurgeon. I soon realised that neurosurgery wasn't for me, I found it extremely sort of stressful and emotionally exhausting, quite honestly, but at the same time, kind of awe-inspiring and amazing. I totally understand why people go for neurosurgery, but it's not for me. But that was extremely useful in terms of, I think, a good way to choose your career is a process of elimination, and you shouldn't ever be rushed into choosing something. Gradually, just experience different things, and you'll find what's right for you. There's a lot of things I could have gone into, but they didn't sort of suit me and my personality. And you'll also find another key is whether you specifically get on with people in that field. You've got a lot of stereotypes and a lot of different specialties, and you'll find that you click with certain specialties and certain people more than others. And it's one of many reasons why you should choose that specialty.
You're talking about kind of stereotypes or personality groups. What is the personality group within general surgery? Where do you kind of fit into that?
Yeah, that's a good question. It's a really hard one to kind of put into words. And actually, there's a lot of variety within general surgery. I just found that I always got on with general surgeons, particularly, I mean, I got on with a lot of people, but I really did get on with general surgeons more so than other specialties. And there's always exceptions to the rule. I don't want to put any negative spin on any specialties, so I won't name any names. But there's sort of some specialties are a bit more holistic and potentially caring than others. And I found that general surgery was one of those, despite its reputation. You'll get a lot of reputation. You'll hear a lot about surgeons being, type A characters and not caring. And, it's just not true. Maybe in the past at some point it was, but I think to be a surgeon these days is not about operating. I mean, operating is a small part of the job. You need to be able to make, the sort of key is decision-making and communication, which, you've got to really get all of those aspects right before you can be a good surgeon.
Excellent. I'm just going to open up the Q&A thing again. It's going to make me stop sharing this screen, which is going to make our faces larger.
Okay.
So I'll just give you 2 seconds.
It's a good warning for everyone.
Cool. Okay. Yep. So the most popular one was kind of what are the best and worst aspects of being a surgeon, but I feel like we've probably kind of covered that with the good and the bad parts before as well. Next popular one is kind of how do you balance your social life with being a surgeon?
Yeah, I think to go back to I would feel that I've got a good social life. I regularly keep up with friends from university and school and work, and I don't think that being a surgeon stops me from doing those things. There are the odd events where I'm going to have to miss them, but you get that with a lot of jobs, and you do have to commit to night shifts and evenings and weekends. But again, most medical jobs you have to do that. There are some you don't, general practice, dermatology, for example, psychiatry, and you like those and that's your thing. That's great. For me, I think a 9 to 5 wouldn't make me interested enough. I like to have the flexibility.
Cool. Just looking through here. So there's a couple of questions from students in here about kind of preparing for interviews and things like that. We don't necessarily want this webinar to be around the kind of application advice and guidance. So any questions in there, we'll probably just skip over those types of questions. We do have webinars coming up around the kind of around interviews and things like that. So if anybody's asking questions around application advice and guidance, just go back and have a look at the other webinars that we've got coming up as well. We want to kind of keep this focused around insight into being a surgeon. So we'll kind of focus on some of those questions. So the next kind of one down is, what's the hardest surgery you've ever carried out or been part of?
That's a very good question. I think there's probably not one specific surgery, but there are several surgeries. I mean, all the neurosurgery stuff I saw as a student was amazing. I don't know how they do it. Honestly, absolutely amazing. I'm sure as with anything, it's a learned skill, and they say that you could teach surgery to anyone. Anyone can do it, regardless if you feel you're clumsy or not dexterous. You can do it. It's just a learned skill. But yes, all of the neurosurgery is amazing. I think a lot of vascular surgery is really amazing and really impressive. Again, I always find vascular surgery difficult. So for example, a AAA repair, so that's an aortic aneurysm. So when the main artery in your abdomen or your belly swells up, when it's more than 1.5 at size, so 5 centimeters or above, it forms this balloon-like aneurysm, and it's at risk of rupturing or bursting. And what you need to do is open the abdomen up, move everything out of the way, the bowels, etc., clamp above and below and fix it. And that's amazing surgery. Again, the head and neck stuff I find really impressive. The anatomy in the head and neck you get these tiny nerves and vessels everywhere, and it's really impressive what they can do. And again, within my specialty, so for example, some of the liver and pancreas surgery, something called Whipple's, is a really difficult surgery that I've seen and not done myself. A total colectomy, where you take out our entire large colon, I've done myself. It's a difficult procedure and takes a long time. So there's not really one specific surgery, but you'll find along your way, you'll see all these different specialties and all their different surgeries, and they all have easy stuff and hard stuff, and you'll just find what interests you.
Okay, excellent. And that kind of links into this next question, which is it's about the career path of a cardiac surgeon. Is that any different to yours? Is that any longer?
Yeah, it is. And these things are constantly changing, so I wouldn't worry about the specifics at the moment because they change every few years. But currently, there are a few specialties which are what they call run through. So instead of having that core training part of CT1 and CT2, you start at ST1 instead of CT1, ST1, and you go straight through. So you don't have that between core training and ST training. For some specialties, you don't have that gap and need for a further interview, which is some people see as a benefit. So examples of those specialties include pediatric surgery, neurosurgery, cardiac surgery, pediatrics, radiology. I think are the main ones. There are potentially some others too. However, there are other routes as well. So you don't have to do this set path. That's just the sort of mainstay of what people do. But again, I wouldn't worry about the specifics because it will change at some point. And they're talking about making general surgery run through. They're talking about other options. So things will change. What you'll also hear is about competition and how competitive various specialties are. So the way they measure this is with competition ratios. So that really is how many people apply to how many people get a job. So for example, I had a quick look earlier because it changes every single year. So for example, if you want to be an anaesthetist, it's a 1.5% ratio. So for every 1.5 people applying, one person gets a job. If you want to be a cardiothoracic surgeon, last year it was 8.42. So that's 8 people for every place. And core training is sort of 3, plastic surgery is 3, etc., etc. What I will say is I would ignore these numbers because they change every single year, and there's different numbers of jobs, different applicants, numbers of applicants, and actually, if you want to do that specialty, don't let that put you off. Just do what you want to do and ignore that. People get so obsessed with competition and competition ratios, myself included at one point. But you've got to realize that your application, whether you have to take an extra year or two, it doesn't matter because you're going to be a consultant for 30, maybe 40 years. So actually just do what you want to do. So
this next question, you can pass on this if you want, but it just kind of says, how do you deal / cope with making mistakes in such kind of high stakes environments?
Yeah, I mean, to be honest with you, I think that becomes more of a concern as a consultant, because for every patient, they have a consultant's name above the bed. And whilst there might be errors, mistakes, or complications, the consultant always has ownership of that. But of course, you're going to have an emotional impact of a mistake. I mean, fortunately, touch wood, I've not had any catastrophic complications or mistakes or errors, but there are little things along the way. And I think the important thing is to reflect upon it. And I know people hate that word. People hate reflecting, but actually, even if it's an informal thing, you want to just write it down in your own, journal, whatever you want to do, that's fine. But also just talk about it, because everyone has been through it at every single stage, at university, during their training, when they're a consultant. Everyone's made errors, mistakes, seen complications, seen bad things happen, and they've got over it. But the way to get over it is to talk about it. Too many people sort of bury their heads in the sand. And I think we're getting better as a culture in the NHS at talking about these things. And there's still an element of a blame culture, which I think we're working away from that. And generally it's working towards a fair culture, a just culture, and people are talking about these things more.
Yeah, reflection is something that we absolutely bang on about this to students that join our courses, and because it's so important. If you can learn to reflect now when you're kind of 16, 17 years old, it's going to follow you through your entire career, through the good things that you do and through any mistakes that you make. It's going to make you a better doctor, and it's going to make you a better person as well. So yeah, kind of acknowledging mistakes is step one, and then learning from them, reflecting on them is so important in anything you do, whether it's surgery or whether it's your personal life. It's it's a good thing to learn.
So true. Yeah, completely agree.
A question here that says, it's probably quite relevant in terms of kind of the buzzwords that students use when it comes to personal statements and things like that, but it's, what would you say is the most important quality for a surgeon?
I think candor. So basically being honest with patients and just being upfront. If you've got to tell people the risks of what you're doing and what's going on, and there's no point hiding anything. If a scan's potentially shown something worrying that could be cancer, just you've got to tell them. You can't hide these things. So I think a combination of honesty and communication is essential. But of course, there's a wide variety of various qualities and skills needed to be a surgeon, which include being hardworking, being reliable, but being flexible, a good communicator. You've got to be, to some extent, you've got to be able to learn to do surgery. So you've got to be willing to put the hours in. You don't want to be doing every operation. It's not got to be on the person for the first time. You've got to practice beforehand. But yeah, I guess being honest is the most important thing.
Okay, great. Yeah, I think that kind of variety of skills and qualities is what makes a person good. You can't just be great at one attribute and then be a terrible communicator. You wouldn't be a great doctor or a great surgeon. So yeah, it's really important that it's a nice balance, but honesty is a great one as well.
I think it's really important not to let the ego set in, because that is always a risk within surgery. And realistically, you're not going to be the great surgeon. If you asked everyone as a surgeon, are you above average? They're all going to say yes, but that's not physically possible. You can't be all above average. And actually, you're going to be a good surgeon. You're not going to be amazing. And you've got to realize that you're fallible. You're a human. You can make mistakes, and you've got to realize that.
Do you think the ego was the kind of the ego around a surgeon was much larger in the past? And do you think that's kind of being not taken away, but managed better through better communication skills and things, and people are just much more aware that surgeons are fantastic, but they're no different to a doctor that's on the medicine wards or a GP or anybody else? Do you think that's kind of
100% completely agree with that? I mean, historically, if you were a surgeon, say 50 plus years ago, you would have a ward, which is your ward. They're your patients. No one else was allowed to go on that ward and touch that ward. So that would be, Sir blah blah blah's ward where only his patients are, and he's in charge of everything, or he or she. And it's not right. And actually, we're one part of the team. The team's a really extended team. From the physios, the nurses, the specialist nurses, everyone is involved. And actually, you're just one person. And I think quite rightly, that's being brought down. What I would say is a good video to watch is Sir Lancelot Spratt on YouTube of a ward round, and if I can, I'll send you all the link. It's quite funny.
Okay, cool. Yeah, that'd be good to see that actually. The top question that's not kind of interview related or application advice related. And again, you can use very general figures for this. I know a lot of these figures will be available online and things as well, but it asks how much do surgeons usually earn, which is a semi-important factor in people's decision when they're thinking about their lifestyle as well. And it says especially those that have 10 plus years experience.
Sure. Okay. So, I mean, this information is very easily available online. It's on the NHS website. It's very easy to get. So I won't be able to give you the exact figures, and I would say look yourself. Of course, you've got to say you don't go into medicine for the money, but at the same time, we are well paid in terms of respect to the general population. It's nice to be remunerated for your hard work over the years, but it's not the predominant reason. And actually, if it's really down to money and you're so about medicine, maybe you're going to it for family reasons or pressure, then don't, because there are a lot of jobs which are better paid. But, a starting salary for a doctor might be around £30,000. And when you're a consultant, it would start around £90,000 and it would work its way up. It's often supplemented with some on-call premium money, not a huge amount, and it does gradually go up year on year, where perhaps the average might be 100, 110. And you can get these clinical excellence awards. So if you do a lot of education research, managerial things, and you can apply for these awards, which are money additional to your salary, which then lasts for the rest of your career. And of course, people do private practice. So there is scope to get a good wage in medicine, but it shouldn't be the reason you do it.
Okay, thank you. So just looking at the time, I'll probably just take maybe 2 more questions. Just because I'm quite conscious I want to take up, your entire evening or all the students' evenings as well. So one of the questions that I quite liked to hear as well was, do you find that surgery is still very male dominated?
Yeah, I mean, that is definitely still a problem. And I think it's something actively being discussed and awareness being raised and acted upon, but it is still definitely a problem. And it varies depending on specialty, but a lot of the surgeons which I found really inspiring and great mentors have been female surgeons, and being honest with you, often better doctors. I just think it should be more widely seen. There are certain specialties which it's particularly male dominated. So at the moment, orthopedics, neurosurgery, cardiac surgery, particularly, whereas there's more female surgeons in, for example, urology or pediatric surgery. But it is something that's, I think, will catch up, because at the moment there are more girls or females than males in medical school and in foundation training, and it slowly just peters out over the years. But I think that's something that is changing, particularly with as I say, the change in increasing less than full-time training and less than full-time working.
Okay, excellent. And just for the last, I know this is like a super cliche question, but it would kind of wrap things up really nicely. Of the 450 odd students that are watching here, if any of them are thinking about kind of becoming, or they want to go down the surgical route, is there any kind of advice that you'd kind of give them at this stage that they're at the moment?
Yeah, that's good. I mean, what I would say generally is just let people know what you're thinking of doing. I mean, the number of people I've seen who are medical students or junior doctors who, at the end of their rotation, said, oh, by the way, I really enjoyed that. I really want to do surgery, but actually I never got to theatre. But actually, it's difficult to know unless you tell people. And just honestly, it feels daunting to say these things, but you've really got to be politely quite forthright in saying, this is what I want to do. Can you help me with this? And people will be more than willing to go out their way for that. And that includes when you're on work experience. So I don't feel any pressure at this point to decide what you're going to do with your career, if you're going to medicine, if you're going to do a surgeon. If not, I really would suggest keeping your mind open, because a lot of people go into things with a closed mind, and there's a lot of things that you miss in that situation. So I'd really just go into everything and think, is this something I'd like in the future? Yes or no? It could be, it could not be. And if it's not, that's fine. You just take it off your list.
Okay, excellent. Thank you very much. That takes us up to kind of 10 to 8. That seemed to absolutely fly by. So thank you very much for taking some time out this evening as well. We really appreciate it.
Yeah, I mean, those are some absolutely fantastic questions. And, hopefully we can do further sort of webinars or other events in the future. And I really would say, keep your mind open, but surgery is awesome.
The last selling point for surgery there. That's great. I like it. Okay, excellent. So any students that are kind of watching, we will send out the recording of this webinar in a couple of days' time. I'm not going to send the slides out just because we didn't really have any slides, and the video will be kind of uploaded to our YouTube in a couple of days as well. So look out for that. And I think we've got another webinar in about 2 weeks' time. So feel free to register for that one in advance as well. Yeah, that's it from us. We get to wrap it up there. So again, thank you very much, James, for taking the time this evening. And hopefully we'll see you on another webinar soon.
Fantastic. Thanks so much.
Thanks. Bye-bye.
Bye-bye.